morning, good evening, good night, everyone. Welcome back to Lana's Little Things with me, specialist dermatologist, Dr. Lana, as you all know me. And we are rounding out the month of October. And what better way than with one of my closest friends, dear friends, eminent surgeon, Mr. Lewis, Dr. Lewis. I've known Dr. Lewis Ian for we say 400 years, like before time began. So, uh, what he has forgotten, I have not learned yet. We had some gremlins in the system, of course we will, but we welcome you. And because it's a live chat, you are all free to send in your questions. I will field them, and just let's we can go as we are. So, let me just give a quick introduction into Mr. Lewis. Ian, I'm gonna find I have a hard time saying that. So I'm just gonna say Dr. Ian, and Dr. Ian is
That's
quite
fine by
happy.
me.
There you go. That's fine with me. So his bio. And remember to like and subscribe, share with a friend because this one is gonna prove to be, as we say, hot. Because we want to make it relevant for everyone. You're going to make it not a didactic. This is not a lecture. Here we do not talk about, doctor patient things. We talk about bridging gaps, living life, family caregiving, entrepreneurship, and just life itself. And because we're rounding out October, Breast Cancer Month, Mr. Lewis, who is Dr. Ian, whatever comes out, just answer because it's your name, right, Ian? There you
Yes,
go.
ma'am.
Thank you.
Yeah.
Thank you so much. And any questions you have, as you said, please send in the chat. So I reading his bio, which obviously your grandma's already system, so I have to open it again. Mr. Ian Lewis studied for his primary medical degree at the University of the West Indies, Mona, that is right in the Caribbean. Everybody knows Jamaica, so it's Jamaica. He had obtained his Bachelor of Medicine and Surgery in 1993. Not dating you, Ian, but after internship, he performed middle management roles of, as we all do, senior health officer, and then go into what your specialty is. So you become registrar, and he did general surgery, urology, orthopedics. He's also co-authored and presented scientific papers while working at our public hospital and was involved in student teaching as well. He then obtained his postgraduate training to further his passion and became a fellow of the Royal College of Surgeons of Edinburgh in Scotland in 2001. He is one of two surgical specialists uh, in a
Wow.
hospital, Peebles Hospital in British Virgin Islands, from 2003 for a year. And there is where he developed, as he says, his passion for breast cancer, from breast management, and a liking for breast surgical oncology, the study of cancer, and then completed clinical attachments in breast, colorectal disease, which everyone knows, cancer of the colon, melanomas, which are less likely familiar, but these are cancers, lesions that look like moles. So he's been in private practice, and 80% of his work is breast disease related, which is why I really wanted to have Ian's input on this. But as you see the title, we're going to have we're going to present facts, we're going to present figures, we're going to talk about it, but we're going to do it with compassion. Ian is one of the most compassionate persons I know. Even his voice puts you at ease. We always see he could just anesthetize you with his voice. He's not, the true surgeon who says, do as I say. Although he does sometimes. But anyhow. And he's consultant at Cancer Society for the last 15 years as a volunteer. He's on the Barbados Medical Council, which is our local professional regulatory body. And he has special interest for patient driven factors that not taking the medication. So things such as high blood pressure and diabetes, all the non-communicable diseases. He also manages lymph nodes. Nose might come in cancer because there may be spread, and educating the community. So my personal link with Mr. Lewis was from the hospital, in how he operated, and then knowing that he is the best person I could find, most compassionate to talk to us, not only from a medical, surgical point of view, so that you can have your questions answered, but also to tell you that there is a future beyond the diagnosis of breast cancer. So, Dr. Ian, Mr. Lewis, welcome. Thank you. Leave your questions. Say hi, Bob. Hi, nice to meet you. So you'll see me talking to strangers. Yeah, I'm not talking to myself. There's actually people online who are sending their messages. So if you want to say a hi back, if you know Rob Wilson, thank you and welcome. Leave your questions. I'll fill them to him, but let him take it away. So, Dr. Ian, please, you told us about your passion for breast cancer, but what was there anything specific that drew you to the concept of like what's happening? Why would you go into breast as opposed to any other
Mhm.
aspect of general surgery?
Yeah. Good evening again, Lana. As you say, it's not going to be a didactic discussion. It's going to be um, kind of a. I came totally unprepared in terms of a scientific discussion, so it's just going to be a conversation, and I'll
Okay.
be guided by you and guided by the audience. From I knew myself on entering medical school, I always wanted to be a surgeon. And my dilemma came when
Sorry, that was me calling you, but
I
I
go to
have you
exit
here.
undergrad training. I did not know what type of surgeon I would have become. And at the end of the day, I had decided I was going to be just general surgery, just do a bit of everything.
Okay. Yeah.
Um, I made a decision to exit the public system after being there for a while. And lo and behold, I got a call to come and be a plug-in surgeon in a northern Caribbean island. I remember the call to this day, and I took it. And I was supposed to be there filling the gap. The prime minister of that country, who was a surgeon, had just won the elections. So they
Okay.
needed a surgeon to come and fill the role for 3 weeks until they could fill the gap. I went, and I was coming from a situation where we manage breast cancer regularly in Barbados. Regular diagnosis, and as a student, as a junior doctor, you were exposed to breast cancer management. And I ended up in this
Yes.
situation where in this island, breast cancer was a novelty. So
Yes.
when I went
Okay.
in I think it was 2003, the first set of local breast cancers were now being diagnosed in a consistent way. And basically, they turned to me because they knew I was coming from a position of a country that had high breast cancer rates and somebody who knew how to manage breast cancer.
Okay.
So all
So
the cases
while
fell
we
at my
pause, we
feet.
say hi, Beverly. She says hi. So keep
I,
going.
So all the cases fell at me, and I liked taking patients from position X to position Y, and I
Mhm.
decided that I was going to make that my subspecialty interest, managing breast cancer. So
Okay.
that's where I journeyed to the UK to do some super specialty training, and then I came back basically as a breast surgeon. So that's it about me in a nutshell.
Whoa. Okay. So then what have you seen? What have you noticed? As we said, we know in Barbados, there is a high incidence of breast cancer. Probably we think sometimes high, I think sometimes it's higher than norm. Can you shed some light on why Barbados has such a high rate of cancer?
It's hard to talk breast cancer without getting into the science of it,
Well, let's
because
go
as
there.
as a
Let's do the facts and
scientist,
figures.
you really need to separate emotional from the factual.
Yes.
And if I were to tell you um, what I think the causes were for the elevated rates,
Iron.
maybe I'd be parroting a lot of people who, out of emotion, would say things like maybe it's in the water. That's what people say a
Yeah,
lot. Maybe it's the stress. But as scientists, we have to put things on the table that we can prove,
that's
and you
right.
can only prove things through um, investigative means, through research.
That's right.
We do have some research in terms of cancer incidents, and especially breast cancer incidents. And there are certain things we'll get into a bit later on. But in general, this thing called breast cancer is all encompassing. It's a disease that it's the most forward disease when it comes to visibility. Um, Obviously, because the work that goes into the advocacy, the sheer numbers involved, the fact that famous people have come to the fore, and so on. That has led to breast cancer being the prototype in terms of this is the bad boy that we want to beat.
Yes.
Um, our rates in the Caribbean are considered high, in fact, extremely high. But when we compare to the North American experience, their rates are actually higher. And when
The
you,
entire the entire North America, obviously they're bigger.
yes,
Is that just because they have more people?
not necessarily. If you think about it, cancer per se it's a genetic condition. Something goes wrong with the genes. It may not be that you inherit bad genes to cause cancer, but at some point in time in your life, protective genes go bad, or rogue genes just come about. So whatever the cause is, the one of the common pathways that leads to cancer is bad genes. So if we
Yeah.
label cancer as a genetic process, a gene process, we have
Right.
to look at the genes of the persons involved. The the best way to study gene patterns is to look at the diaspora. The diaspora. We look
Yes.
at, we're not excluding white people. We have white people living in the Caribbean, but the sheer numbers would tell us that we need to look at the Black experience in the Caribbean
Hmm.
compared to our genes, our forefathers who came from West Africa, and then
Yes.
compare
Right.
it to the further diaspora now in North America. Um,
Oh, that's
Interestingly,
okay.
that's that's a juicy kind of inquiry that has captured the attention of quite a few scientists. If we
Okay.
are West African, and we are,
Yes.
I mean, give or take some dilutions because of intermixing with other races and so on, we are really West African. Our cancer rates for breasts should equal what we're seeing in West Africa in the Black population, and it should equal what we're seeing in North America.
In their
That's
black
not the
population.
case. Their Black population, but that's not the case. So what we actually see is that in the what we call the sub-Saharan African populations,
Right.
breast cancer rates are actually quite low. They're on the increase, but they're pretty low. Breast cancer rates of the Black population in the Caribbean, intermediate, and then the Black experience in America is high. So as you go from West Africa and you come across the Caribbean and then you get to North America, you
Hmm.
get an increase in breast cancer incidence. So that is telling us that it cannot only be genetics that's at play in breast cancer causation. With the migration out of Africa, something must have worked along with the genetics to increase the cancer experience.
But that's encouraging because otherwise, then, if it was only genetic, then I can see why people would give up. The tendency would be to give up because if I only inherited this and this is what I picked, well, then I have no control over it, over whether
Correct.
I get it
Correct.
or not. So it's good
Yeah.
to
So
say,
right now,
and
maybe a
that's
little bit
well,
of a
one
cop out.
question: how much the part from Miss Adamson does the environment play? If genetics is one part, you're going into the environment now, I'm sure.
Yeah. Yeah.
Yeah,
That
excellent question.
that's where the majority of the research is going. What are the environmental factors at play?
Right.
Um, Let me give you a statistic that may be a bit surprising. Most of the cancers we see are
Uh-huh.
not, as people would say, running through the family. They're not genetic.
Yes.
So most cancers, 80 to 85% of cancers in Barbados are what we call sporadic cancers. You can't look back in that particular family to say that, look, this is a breast cancer that's running through the family. It just
Right.
occurred in a person without a family history. So that is telling us maybe environmental factors are probably more significant than genetic predisposition. Now,
That
what are
is
some of the environmental influences? You can think about things that we put in our bodies and things that we go through. They've looked at, it's probably easier for me to list things that they've looked at many times to say, look, this has been proven not to be a cause. Things like aluminum in deodorants,
right.
consistently proven not to be linked to breast cancer. The wearing of underwire brassieres, proven not to be
See, you know
involved.
that's gonna be controversial, right? Because that was like almost gospel.
Yes, yes. Lots of patients come with this predetermined notion that wired brassieres were the culprit. So those
Wow.
things have been thrown out consistently. What is controversial and what may have a little water to it is exposure to artificial lighting.
Mm-hmm.
That's coming into vogue again. They're actually saying for hormonal reasons, women who work shift work at night and
Right.
probably at the same time who have a predisposition may be putting themselves at risk. And it has to do with a certain hormone that increases when we are exposed to artificial light. But
Wow.
hormones, the use of hormones, there can be no question that exposing our bodies to what we call outside the body hormones in the form of the birth control pill, hormone replacement therapy, could be putting us at risk for breast cancer. But admittedly, the risk caused by these hormones have been probably overstated through the years. There's a risk, but the risk is not as high as people would think. But there's a risk associated. Now, there's certain things that we may have control of,
Mm-hmm.
but unless you have the knowledge, you may not know how to adequately use it. Um, if you think of the female body and the male body to a certain extent as being subjected to hormone cycles throughout life, especially in a woman, that woman who's exposed to more cycles per her life is probably at higher risk for breast cancer because she's exposed to more estrogen. So the more menstruations you have, the more likely you can have breast cancer. So a woman who starts her menstruals early in life
Mm-hmm.
and and at the same time finishes late in life, that lady is having more estrogen cycles compared to somebody who started her cycles late in life and finished early.
And why is that? Pray tell.
Because menstrual cycles are estrogen cycles and it dictates that you're exposed to more estrogen. And estrogen is a determinant of genetic damage for breast cancer. So
Okay, so
more
is
cycles
estrogen
in a
not protecting?
lifetime.
So
No,
estrogen is damaging, not protecting?
estrogen and the derivatives of estrogen can be damaging to the cell and can lead to breast cancer.
Huh. Okay. All right. So
So from
that,
let me finish that up by telling you that um, Professor Hennis, you know Professor Hennis,
oh yes.
he's a researcher that a lot of us in these parts we have a lot of respect for him because of all the work
Definitely.
he's done. He
Yes,
has done a
tremendous.
study to suggest that probably the commonest risk factor in Barbados, and we can only speak of the Barbadian experience,
Hmm.
the commonest risk factor for breast cancer for a period that he studied, I believe it was the early 2000s,
Uh-huh.
was not having a child. Having a child is seen as a protective um, thing when it comes to stabilizing breast tissue. Having a child, not having a child is risky.
Okay. Not having a child is risky when it comes to breast cancer. We
Yes.
used to have a
So
saying in
in other words,
years ago.
having a
Mhm.
full pregnancy before the age of 30, maybe
Right.
we should be pushing our ladies to, in terms of family planning, we should be pushing our ladies to get towards that, you know, trying to have
Towards.
that first full pregnancy before the age of 30. It has been proven to be protected.
And if you've gone past that, then what?
But a risk is just a risk. It doesn't mean you're going to get a disease, right? But keep it in context. If there are other things at play, if you do have a family history, and if you have other things in your history, then you probably want to be, you know, if you know you have a risk, then you may decide to screen as opposed to somebody who's not going to be screening and so on and so on. But having a
Okay.
risk
Right.
is just having a risk.
All right. And what? So now we come into screening. I don't know if this is where you wanted to jump in on screening, but
Mhm,
I've been given some short information all month and reading and the research, and especially because my focus is on gerontology.
mhm,
Cancers don't read the books. So I've been noticing patients over 70, yes, with lesions, as well as those under 40. But yet we're told, go for 40, 45. Is there any reason, except if a person feels a lump, that they should go for a breast exam, or do we just follow the guidelines unless you feel a lump? And, and if so,
Screening,
what
screening
do we
is
do?
screening is probably the most controversial part of breast cancer management. And
Agree.
by management, we mean prevention, treatment, and so on.
Right.
Um, if you put 100 doctors in a room and you ask, do you believe in screening for breast cancer? Half will say yes, half will say no.
That's
Because
right.
there's no hard and fast rule, there's no black and white, there's no right or wrong. Um,
Hmm.
put you on the spot a little bit, Lana. What is your understanding of a screen? What is a medical screen? Or anybody in the chat can probably shoot the answer in. What is screening?
Am I gonna lose marks if I don't say the right answer? Me. Oh
Yeah,
well, I'll go for it.
may get some spankings
Well,
because there's
screening
an
as
important
advice.
concept that we need to have down pat.
So, screening starting from the age of 40, uh,
Mhm. But
45.
in general, not necessarily related to breast. What is a screening test?
Oh, a screening test is essentially you mean for breasts or you mean for anything?
Any condition.
Oh, where we just either randomly or specifically when we find someone or someone goes to the doctor, we test for bloods or examinations, lumps, lesions, anything. We are just looking overall for something that is wrong. We are not
Right.
specifically assuming something is wrong, but we are going to look to see, examine the person and say, oh, you're in good health, or I see a mark here, or I
Mhm.
feel a lump here. So a screen is just like that. It's like, let's look all over and do the logical things and see if we find something. And then you go further. Eh, How
Okay.
many marks do they get or lose?
80.
Okay.
All right, we have two ladies, both presenting for mammograms. One lady can feel a lump, and that's what took her to the mammogram. One lady can feel nothing, but yeah,
Yes.
she's going for a mammogram. Which lady is actually screening?
The one who felt nothing. She just
So,
wants to know.
yes. So, the true definition of a screen is what you said. You're quite correct. But remember, a screen by definition is a test applied to an apparently normal population. We have to make the distinction between screening tests and diagnostic tests, right?
Okay.
If you have noticed something in the breast and you go to get a test done, that is no longer a screen. We
Right.
want you to be coming for your mammogram when there's nothing to you, there's nothing going on in the breast.
Can you say that one more? I'm just for emphasis, because
Yeah.
I think persons think it's only when I feel something. Most people are getting around to like just check and make sure. But can you
Mhm.
just reemphasize and say that again, please, for the audience?
So I'm just saying Miss Adamson's comment. She's
Yes.
correct as well. But remember, we have to add in that a screen is a test that is applied to a population that is apparently healthy, and you're hoping to find a disease process early. That's the true
Right.
definition.
Right. Because
If you
anything can
wait,
go wrong at any
yes,
time with anyone. So we just want to be
yes.
sure. Just like how we check our
No,
pressure,
no, the
that
point is
sugar and so.
if you subject an apparently normal person to a screen and you find something, chances are you're going to find it early because that person is symptomless. If you wait until you're checking up behind a problem,
Yes.
you may be catching a disease process late.
The
So a
horse milk needs to be
screen
on the stable.
best intervenes in a person's history at the early phase.
Okay.
So we
So
can
so
screen for
then
breast cancer. We can screen for any disease process, high blood pressure, cholesterol, anything. But the
that's right.
point is, you want that person to be doing the tests when they feel okay and when they can't appreciate anything wrong.
And why is that? And then because for some people that starts with a paranoia of, okay, I didn't see anything this year, but I heard I had a friend who they saw nothing, and then the next year she had cancer. How would you allay that person's fears
Well, I
and
mean, if
encourage them that screening still matters and makes sense?
what it's precisely what we said just now. If something is picked up on a screen and you are healthy, you're feeling okay, it means what is picked up is going to be early. If you wait until you can feel a lump, then to move in to get your mammogram, you maybe we, no guarantees can be given that the disease process is early. So a
Right.
screen is supposed to interject in the natural course of a disease to
Mm-hmm.
capture a lady who is
Mm-hmm.
so early that she feels well and who
Mm-hmm.
has given us, the medical community, a chance to get her cured because we're picking the disease process early.
Okay, so I'll stick a pin in the
Why?
objection to that. Why
Mhm.
then? I'm well. I'm going to check. Nothing's wrong. There are persons who may want to know the blood pressure, but then they say, you know what? I'm not going to go to the doctor just in case it's high, and then I die. There are people who
Well,
are
I'm glad
afraid
you
to
raised
check
that.
to
I'm
know.
glad you raised that. So that opens another um, another
Yeah,
issue, right?
right.
Who really is in charge of a patient's health? Who has the ultimate charge of a patient's health?
Can the audience please, by show of yes or no, me, doctor, just a few comments. We can wait for them.
Mhm.
Who do you think is more responsible, the patient, yourself, or the physician for, you said your medical checks?
Practitioner, yeah.
Okay. So I see everybody's come in. This is where you can, this is not a poll, no marks, no lashes. Just, do you think you're the prime responsible person for your health, or the doctor has to do it? And we're giving you 4 seconds to reply. 5 seconds. Okay, we have patient. Who else is gonna be? Who's gonna take up the mantle and comment here? All right, two
And I'll
seconds.
jump in
I
and
know
say
my
Rhonda is
4 seconds.
spot on.
All
Rhonda is
right,
spot
but there we
on.
go.
All right.
Oh, another person
Now,
said the person. You're
the
both correct,
person,
Miss
the
Green
patient,
and Miss
yes,
Anderson. Excellent.
yes, yes, yes. So if you think about it, I can think of one instance where government actually intervened to mandate screening. And whenever I give public talks, I give the example of in Japan, just like we have breast cancer and prostate cancer and now colon cancer as public health issues, in
Yes.
Japan, remember, Lana, they used to have gastric stomach cancer as an issue,
Yes.
and their
Yes.
numbers were off the charts.
Off the charts. Yes.
So government kind of intervened and said, look, we need to get these numbers down. And they were kind of mandating certain tests to be done, especially at the corporate level. But apart from that, I can't tell you I know of any examples where people were kind of forced to screen. Because the reality is, it's the patient's health, and the decision to screen is at the patient. That's an important designation. The decision to screen or not to screen is with the patient. So, as doctors, if a patient decides, look, I don't want to do mammograms,
Right.
it is not within our purview to try to change that person's mind. We have to work with them to find alternatives, and better yet, to find why they don't want to screen, to see if they're, irrational fears, etc. But ultimately, it is the patient who makes the decision.
Okay.
So that's why there's no right or wrong when it comes to, do we have to do mammograms? There's no right or wrong. We
We're
give
just
the
encouraging
information.
you to check.
Yes, give the information and let patient decide, and then work with the patient.
All right. Awesome. So going in now to environmental factors, what would be the, and this can cover diet, lifestyle, and so on. But I mean, environmental. Do you think that the environment we're having, as in the heat, the everybody says something about everything. The air that we're breathing, the water we're drinking, as you said initially, it was the water. Food we're eating that persons are convinced because it's more processed. It has more things that cause cancer, so we need to stick to ground provisions. Others say no, stick to just green leafy vegetables. Some say just eat everything in moderation. Would you say that there are specific foods to avoid, or specific foods to um and specific foods to use?
But
Like
I'll give you this comment. The American authorities, and we step off of America a lot because they've done the bulk of the research this side of the universe. They have picked up that if patients were to address three things, they
right?
will be 38%. And I know this stat well because it's what I do for a living. And whenever you give talks and you give this statistic, you just watch people's faces. You're stuck. No, Lana, I'm not seeing your expressions.
See my I was like,
Yeah.
why do I
Your,
look so
your screen
frozen?
is stuck. Yeah, yeah. Anyhow,
Okay.
but listen
I'll
to this.
refresh it a few minutes, but everybody can see you. That's my. You can hear
Yeah.
me
Okay. I,
clearly.
I can hear you well. I'll proceed. I'll proceed.
Let's see.
There are three things. If persons were to address these, there would be almost 40% less cancers in America. And we should be no different. Physical inactivity, obesity, and alcohol
Physical
as of
activity,
physical
obesity.
inactivity, obesity, and the use of alcohol. It has been proven,
And why is that? You know you're gonna ask why is that?
yeah, yeah, it's been proven that in persons who have had cancer, breast cancer, a lot of times women qualify for tablets to be used afterwards as a protectant, tablets called hormone blockers.
Right?
It's been proven that if you have a cohort of women who don't use the hormone blockers but who exercise, the protective effect of exercise is almost as much as using the tamoxifens and so on and so on and so on. That is dramatic news. Exercise, a natural process, is almost as powerful as the drugs that we're packaging in terms of cancer prevention. And it must
Um,
have to do with the fact that exercise produces um, good chemicals. It tones the lymphatic system, which is the system through which cancer likes to spread and so on. And it probably makes the liver more efficient at working. The liver is the seat of depoisoning in the body and elimination through the urine eventually and the stool. Obesity, the bigger you are, the more sources of estrogen you have in your body because the estrogen hormone doesn't just come from the ovary, it comes from fat cells. So obese persons will be more estrous compared to thin persons. As of as of about 5 years ago, the WHO, the World Health Authority, made a big statement. There is no safe limit of alcohol use. I'll
say
say
that
that
again.
again. There's no
Yeah.
safe limit for alcohol use. In the past, we used to tell patients, "Oh, drink a glass of wine a day will be okay. It's good for your heart." Or and I remember for years we were saying 1 unit of alcohol per woman and 2 units of alcohol for a man should be relatively safe. But no, the WHO is saying, look, there is no safe limit for us to advise as per alcohol use. So as
And that goes for anything, Ian. That goes for breast cancer too.
it goes for breast cancer, it goes for what we're seeing is a dramatic rise in colorectal rates in the young. And the thinking is that alcohol binging is probably causing a lot of that disease. So what we are supposed to tell patients, if you're going to drink alcohol, keep it to a minimum.
Okay, well,
So when
I
it
met
comes
a
to
friend in the
things,
supermarket today, and we were talking the very same thing that we need,
mhm,
like, a little drink, a little sit down drink for the nerves. Not because you're going to be drinking the whole bottle. And that's our culture ish.
yeah,
Have a drink for the worms. Have a drink for the for the sake of your stomach. If you have anything wrong and there's gas, drink something that will kill whatever's in there.
I don't think the authorities are saying you can't ever use it, but they're
Right?
saying it would be wrong based on the evidence. It's wrong for doctors to give the impression that there is a safe range for alcohol. It's
Uh
risky. Alcohol is risky. That's the bottom line.
huh.
So
Okay.
these are three things. When it comes to environmental things that we can influence and manage, if managed in the right direction, there'll be less cancer in the world. Being physically active, not being overweight, and not consuming too much alcohol. So when people ask me about the environment, I say, look, before we get to the water and the barbecue and so on, these are three personal things that people can invest in. Now, the whole idea of foods that we take in, that we internalize and so on, gets very, very complex because apart from a few examples of definite cancer chemicals that enter our bodies. And when I talk about that, you're talking um, foods that are prepared at very high temperatures. So that would be barbecue foods and grilled foods. You know, we are taught that grilling is healthy from a cholesterol point of view and so on.
Right.
Foods that are prepared quickly and at a high temperature, they do have a layer of cancer-causing chemicals, nitrogen-based chemicals in them. Animal fats
And
can
that.
be carcinogenic. I mean, bacon was added to the list of carcinogens about 10 years ago. All right. So, but
Bacon. Yes, I remember bacon
bacon
was
is
added.
actually is considered a carcinogen.
Yes.
So what I want to say is, apart from those known influences which come in the food, people now talk about the nanoparticles in the environment and certainly the water and so on, which may play a part. What may be greater at play is something called the epigenetic influences. And Lana, when we talk about genetics, we talk about inheriting traits from our parents, yeah? If daddy
Well,
is tall, we
yeah.
may get the tall gene and we become tall. So that's inheriting a characteristic. Understood? That's the
I
genes.
understand.
That's a
You're back
genetic
at genes again.
influence.
Yeah. Yep.
But when you when you talk about epigenetic now, there's certain aspects of the gene material itself that is kept stable through generations. Um, but the actions of the persons with particular genes can influence those domains of the genes that are considered stable. And the new instability can be passed on to future generations. So that's what we refer to as the epigenetic influence. So let me give you an example. You have a stable gene, and remember we have our genes are found in chromosomes, and the chromosomes are bundled together into cells. So let's say your grandfather was a smoker.
Right.
The smoking may influence in a bad way the stable part of a gene, causing it to become unstable. And that new unstable gene is now in a heritable form, it can be passed on. So, in a way, rather than inheriting a characteristic, you're inheriting an action of your foreparents. My personal
Action
belief,
or
my
a genetic predisposition or a
no, an
gene of them.
action. So the gene is the characteristic. The epigene is that change that occurred because of an action of the individual. And the epigene can be passed on to future generations. So let's say your grandfather smoked, he may have set you up to inherit a cancer gene. I have a sneaky
Mhm.
feeling, and there are lots of other authorities who agree, that a lot of the clusters of cancers you're seeing in the Caribbean and so on, they're due to the epigenes passed on from 2 generations or 3 generations back.
Yes. So persons who are thinking, and this is important, even though you can't see me, guys, you see me all the time. Don't worry, we'll get the gremlins out of the system. But and I know for some who are looking on YouTube, it sounds like it's muted. I've changed that for you. Um, the who are listening from your laptop, there may be some who are hearing and not hearing. But what I've noticed is that the people who are saying that we have we have this, we have the gene. We gone 300 years, 200 years. You know, my mother, I only need to go as far back as my grandmother, for example,
Mm-hmm.
who might still
Mm-hmm.
be alive. So you're 20 and
Mm-hmm.
your mom is 40 and your grand is 60 because everybody's young and new and fresh still.
Yeah.
There's no longer like 100 or 200. We have not gone back that far. So
Yeah.
I think it's important for persons to recognize that genes take a while. Think this is a slow process. So even if
Yeah.
your great grand anything didn't have something, it doesn't mean this generation above her didn't have something that can now like skip and end up at you,
Yeah.
which is what you're really trying to say.
Yeah.
If I'm
Well,
putting
the,
that
the, the
correctly.
epigenome theory is suggesting that those bad genes can come out in as little as two
As little as how
generations, and
many?
you
I
can
think I missed that.
and you can see effects. So
Wow.
the epigene theory is kind of a short-term theory to explain cancer crowding in a small community or a small country within a short period of time, meaning within about 50 to 60 years. But that, like I said, that kind of segues into a talk in itself in terms of the theories of cancer causation. I want to balance that by saying that despite the world authorities predicting that three cancers will continue to be a problem into 2070, well, four cancers, really, four cancers:
Yeah,
breast,
any more? Think
mhm,
before you finish, in case we get any more. Go ahead.
mhm,
Breast.
breast,
Oh, you want me to go?
prostate,
I'll go for marks. Breast, prostate,
prostate,
colon,
colon,
um,
and lung disease,
lung.
lung
Now we're going
cancer.
for lung. Okay,
They will
wow.
continue to increase over the next 50 years. It is expected breast cancer is the most common invasive cancer in the world now. It took
Oh
over
my
from lung
goodness.
cancer just 2 years ago. It
Mm-hmm.
is anticipated that by the year 2035, the commonest cancer in the world is going to be colon cancer.
Right. That I heard. But
It is
and
also
there's
is
no seems to be no stopping that cancer from just doing as
we'll
it
talk
lives.
about it again because I mentioned a little something about it just now.
Right.
Is also expected that by the year 2070, the rate of breast cancer is going to be double compared to what we have now. All right. Right now, we get about
Hmm.
2.5 million cases a year. Is expected
Oh,
that by 2070, it's going to be just under 5 million cases a year worldwide. So breast cancer is expected to
of what? Of
continue.
breast cancer? Wow.
Breast cancer by itself, yeah.
So
The good news
is
is
this
that,
regardless of whether you're trying to do the best you can or not?
but this is it. This is it. Contextually, a lot of that is going to be early breast cancer that probably would never have gone on to threaten a woman's life,
Right?
or very early treatable breast cancer. So the news is not all bad. And the news
It's
is
not
pretty good
terrible,
too.
Rhonda.
No. So I'm giving Rhonda the balance now. The balance
Right.
is that we expect the mortality from the death rates from breast cancer is falling and is expected to continue falling over the next 40 years. So more women will get breast cancer, but we are going to have more and more survivors over the next 40 to 50 years.
Who will
And
have what prognosis? How long will
um,
they live?
that is just a general statement based on projections. So I
Okay.
don't think you can pull out of that what the prognoses would be. But the big
Okay.
question is what, right now, as I've said, the mortality rates are down. Right now, what is responsible for women doing better? And some authorities think is screening programs. And I know there's some fairly harsh critics who said, no, it's the improvement in the treatments of breast cancer. That's a little competition going right there. Is it the mammograms are doing such a good job, or is it the fact that the way we treat breast cancer has gotten better? It's probably a bit of both. Probably a bit of both. There can be no doubt that mammography or the use of mammograms is interesting. You're using something that potentially can be dangerous to tissue, and you're subjecting a woman to that on a regular basis to tell her she's okay. And I remember having a difficult time with that in my career, using X-rays to get a woman to a point of safety. It didn't make sense to me. But my whole attitude towards mammography has changed. And if a woman wants to screen, I have absolutely no problem supporting a woman doing mammograms. But the mortality rates are down. The way we treat breast cancer is getting better and better. The drugs are more and more powerful. The unfortunate thing is, for countries like ours, the good drugs are very expensive. You don't necessarily have the insurance companies always understanding that you need the best drugs to get the best results. So sometimes we are kind of forced to make use of the older drugs, despite knowing that the better drugs are available. And I mean, I've been doing this now for almost 30 years.
Yeah.
And I have seen the system in Barbados go from treating everybody the same. Everybody got the same surgery, got the same meds, and so on. And it was a hit or miss in terms of how patients did. To us now being in the position where we are kind of like the higher authorities throughout the world, we give individualized care based on certain investigations, interrogations that we do in the workup of a woman with breast cancer, recognizing that every single breast cancer is different. So I think our rates of we have, and I want to stress, Lana, and for the listeners, um, we have good specialists in Barbados. We have good specialists in Barbados,
Oh,
and
yes.
one of the challenges we have from where I sit is that our patients don't necessarily trust the medical system all the time. And there are different
That's true.
reasons for that, right? Somebody else who didn't turn out well. If you have overseas influences, the overseas influence is a tremendous influence. You're dealing with a
Tremendous.
patient here in Barbados and they're talking to overseas. You're fighting a big battle getting them to listen to you rather than to listening to overseas. Um,
Oh,
But all those
yes.
things come, as part of it in terms of ensuring patient compliance. You can't get the desired result doing part treatments. That's why I tell patients, if you're in the system in a conventional way and you want to get to the end, there's no point cheating yourself by omitting this, omitting that. Uh, you're either in or you're out. If you're out, then that brings into the picture now the use of alternatives and so on and so on, and that in itself is another topic.
All right. So the question I was going to ask, and the question that Rhonda has brought up is does it make sense? You said you won't deny anybody from doing it. What would you say is the best investigation or to have right now? Combination, ultrasound only, just go straight to Lord knows thousands of dollars MRI. I mean, what is the most practical in between or test that
in a
can be
woman
done?
in a
The
woman in a
screening.
woman who wants to screen in
Yes.
a woman who wants to screen, the mammogram is unchallenged as the number one test.
Okay.
Unchallenged.
Okay.
It works. It can detect early cancers in the form of calciums in the breast. You don't necessarily have to have a lump. You may just have these fine calcium changes. Um, and it adheres to all of the qualifications of a good screen. It's a cheap test, it's repeatable, and it can be administered to a big part of the community. Those are all the prerequisites for a screening test. The
Okay.
test that will give you the best immediate results as to whether cancer is present or not but cannot be qualified as a screening test is the MRA.
Go
But
on.
the MRA cannot be seen as a screening test because it's not cheap and it's not easy to
No,
repeat.
no, no,
So
it's
by
no.
definition, a $2,000 test, a $2,000 MRA cannot be
Right.
classed as a screening test. But $100 mammogram is a good screening test, good value for money. But if you were to ask me which of all of the tests, if money were not a part of it, which of the tests
That's right.
gives the best details is the MRA. But overall, if you're looking at a screening test, which is the best, is efficacious, it works, and it's cheap and is available, it's the mammogram by far. The mammogram and the ultrasound, they look at different things. So when persons ask me, can I skip the mammogram and do an ultrasound? You have to make sure that they understand the mammogram screens for something, and the ultrasound really is an adjunct, an add-on to the mammogram, right? Especially in women with dense breast tissue,
Dense breath. Yes.
right? Because you're developing a picture. It's like photography. If the subject is dense, if light doesn't get through well, then the picture is not going to look good when you're looking at it. So women with dense breasts, we tend to add the ultrasound. In fact, that in some parts of America, that has been made law.
Yeah.
There's a law passed in Florida. If you have dense breasts, the radiologist is mandated to report that you must or you should attend for adjunct ultrasound, just so we can see past the density of the breasts.
Yes, yes. I've heard, I remember hearing that, and I think it's
Mhm.
excellent because this year, last year, and year before, but this year especially, I don't know what happened to mankind this year, but a lot of breast cancers have been missed, not picked up by mammogram, not necessarily picked up by ultrasound, but only then when both were done, then they
Mhm.
could find. And this is with somebody who didn't. One felt a lump and one didn't feel anything. So it was one was just screening, and
Yeah.
one was let me just. I just want to know what
Mhm.
this lump is. You know
You know what's the thing about the ultrasound too?
what's
And
that?
in surgery and in medicine in general, this is a statement we say: the ultrasound is as good as the person doing it.
Well, that is true.
You can have
It's
10
operating
doctors
dependent.
doing the same ultrasound on a patient and get 10 different readings.
That's true.
So the ultrasound is the one that is more likely to be influenced by the person doing the test. In this country,
Okay.
we've had added to the radiologist numbers. I wouldn't call her name because
Right.
that wouldn't be right. That wouldn't be fair. But there's a young lady who does breast ultrasounds here who is just really good at it. And since she has come to Barbados, I have seen her pick up breast cancers on her ultrasound machine that, it boggles the mind how she was able to call this as a suspicious lesion, something that millimeters big. So we have good ultrasonography here, and it cannot take the place of the mammograms, but whenever it is used in specific incidents, it can lead to the detection of very, very early cancers.
Okay. So as we wrap up, because I can't believe an hour is gone. I feel like we now
So
starting
we're on for one
conversation.
hour? It's for one
Yeah.
hour?
Imagine.
Okay.
But
Oh, wow.
close to. And I apologize to my audience because I really the gremlins are in the system, and I am still frozen. But you guys know that you can still hear me, but I apologize that it's me that you can't. I'm still happy that you can see Mr. Dr. Ian, so that you can actually hear from him directly. And I appreciate all the comments. Keep sending them in. This has been fantastic information.
I want
And please
to
spread
I
the
want
news.
to
We're not
end on
finishing
I like
up.
ending on some positives. Yeah?
Right, but we're not gonna finish. We're not gonna end just like that. We have a few more minutes,
Okay.
but I just
Okay.
wanted to plug in because it's important to know that persons know that there are tests that are still to be done, that can be done, that matter when they're done, and not only to go for yourself, but to encourage your friend, encourage an older friend, and make it a group thing. I know women have some some women go in their groups and they have their group mammogram, so to speak. So if you can gather a group of your friends and say, well, let's just go and at least get one test done. One can encourage the other. It's still better to know. The other thing is to remember to um, let not do not let fear of the unknown stop you from going for a test. If you're afraid to go and something is wrong, there's nothing you can do. If you're afraid to go, and courage is not the absence of fear, it's acting in the presence of fear. So I encourage ladies and gents. I just want you to touch on gents for a bit because I've had in this month alone, last couple of days, 3 gentlemen of different age groups with lumps who had to get, and I've never had that. So it must have been that you were coming on, and so we had to get this sorted. So, ladies, please form your groups. Do not be alarmed at the fact that it sounds like, oh, they're going to do this, they're going to do that. It's painful, it's that. We've busted some of those myths. Mr. Lewis has been very clear in the tests that you can get done, the risks that you have. Go for your screening. Um, Screening is to find out most lumps there are non-cancerous, but at least you will know for your own sake. And then remember, genetics play a role. And then, well, we're gonna have to find juice in place in the rum, but I'm sure we can get that one done. And that might be another trip.
Yeah.
But what I wanted to encourage and thank you so is for presenting it in a clear manner so that we have a stepwise fashion. Do your exam, which I still encourage patients to do. Patients find their lumps. I've had several patients who found it. Mammogram didn't find it. They found it, turned out to be cancerous, and then in 2 cases it was metastatic, so it had spread. So we still want to be aware that you know your breast better than anybody else, ladies and gents. Just check them, and if you want to come and check, nobody can stop you from paying money to look at your own to examine what's wrong with you. That's one. So, but I'll leave you. The one I wanted you to focus to just touch on, Ian, is men, and I know you are an advocate for sure for males examining and coming to get tests.
Men are an interesting
And
prospect.
everybody's asking for a part 2, so we're gonna look for part 2. But
Okay.
let's briefly touch on the men.
How much time do we have left, do you think?
YouTube doesn't block me because I have been with them for years. So,
Okay.
but we have. I
Okay.
wouldn't want to. Everybody, go get some tea, everyone, and we'll be here. But I would say let's do 3 more minutes, and we can you
Yeah.
do the roundup, and then we'll do the other bits. So
I,
remember
I
to
think
like and
I think
subscribe
I
and
no
tell a friend.
I think your roundup has been perfect. I don't want to add to it. Good
No,
advice
talk
to.
about the man. Talk about the man. The
I'm
man.
going
The
to talk
man.
about the man just now, but
Oh, oh,
what you
oh,
said just now, it was really good information. I just want to harp on the fact that yes, more and more women will be diagnosed. Breast cancer will remain very visible, very out there for the reasons we mentioned at the beginning. But I think we're slowly getting to the stage where it is not as fearful a proposition as it was years ago, right? And
yes.
I want the audience to know that you have good specialists in Barbados who are equally trained compared to our colleagues overseas. We have some work to do in terms, I think, of the drugs, getting the drugs in fresh, the good new immunotherapy drugs and so on. And the
Yes.
hospital is about to open the linear accelerator. Having a linear accelerator, boy, that's a big, big step for cancer care delivery in Barbados.
Okay.
So
English.
we have it
English.
here.
English, please. English. A linear
No, the linear
accelerator.
accelerator is the most modern way of delivering radiation treatment. Yeah. And
Okay.
this is something that's been needed for a while. Where we can do more, and this is in all honesty and frankness, is our research. We need research that is based on our population so that we stop using stats from overseas and it
Yes.
pertains to us. We have a
Yes.
university, we have subjects, we have specialists who are more than willing I can't figure out why can't we get more research done, right?
In our
Um,
in our setting,
in
yeah.
our setting, in our setting. Yeah, men do not come. I've never seen a man coming to me for screening. Honestly, they don't generate the numbers to suggest that they need to screen. In terms of how many men we see, when I gave a talk about 10 years ago, I was able to follow through and see we had 7 breast cancers that particular year. And that is holding true to the international ratio that we see. Out of every 130 women, one man would have breast cancer. So the ratio of 130 to 1. For years, people said it was 100 to 1, but it's more like 130 to 1. That ratio obtains here in Barbados. We get about 150 new female cancers of the breast per year. And I would say in a populated year, we can get about 6, but in a sparse year, we can get 1 or 2 men coming through. Men have breasts, so men can get breast cancer. Men have
Yes.
all of the biochemistry of a woman is in a man. The female hormone estrogen is in a man, but it's in lower quantities, but it is there. So because men have breasts and they have estrogen, they can get breast cancer as well. Men tend to
Okay.
come late because of the machismo that's involved and so on. And because they come late, obviously you can't come late and expect to do as good as somebody who came very early. But I mean,
Please remember that, gents.
they span the spectrum of being anxious well men to men who would basically never come into a doctor unless they're on death's door. Um,
You know.
I think the best way to handle a man when a woman is engaging the medical system from a breast point of view is just to have the woman encourage her partner, her sons, godsons, just encourage them to be aware of the breast and to report any changes that are sticking around for more than let's say a month. If you have a lump in the breast and you're a man, don't think you can't get breast cancer because you're a man. Have it checked out.
I'd also
That's the
say for
best way to handle
physicians
a man.
too. I would say doctors as well, because we tend to also overlook our doctors. We tend to overlook not doctors. We tend to overlook our patients in
Well,
terms of
most doctors do not examine male breasts. That's a fact.
no, they don't.
Yeah.
We're not routinely. We don't. They don't say okay, and a male would look at you like, doc, why you touching my chest? So I found it's becoming, and but they're not resistant. It's just strange. So anything new is gonna seem new until we get it into vogue.
And you
So
know, Lana, and you know something? Men do get breast lumps commonly, you know. There
more
are 2 times
commonly,
in a man's life where he's expected to get swollen, tender breasts because of
right?
estrogen changes, estrogen, testosterone changes. Adolescence and what we say senescence in the 60s. Those are 2 periods in your life where the relative ratio of estrogen to testosterone changes, and the breasts are going to reflect it. And then there are certain medications that men
That's
use
right.
that can reflect and increase breast size. Smoking, especially the marijuana, can do it, and alcohol. They
We're
can all
back to
produce
alcohol again.
breast enlargement and breast lumps. So
Right.
breast lump is a medical entity. A good doctor, just by taking a history, should know immediately what's the cause of this man's enlarging breast. A little
Yes.
bit of lumpiness behind the nipple and so on. But yes, I'm hearing marijuana smoke. I'm hearing alcohol. I'm hearing he's using the tribulus that some may use, or he's using spironolactone or some of those other conventional medicines to cause it. So
Right.
the male breast, we have to encourage the young doctors to remember that men do have breasts. They do have breast concerns, and if the men don't raise it, we have to be in a position to raise it for them.
Okay, so we be their advocate. Ladies be our gents' advocate. Gents be our own advocate. We ladies can do everything. And also, just be aware that things are changing as you get older. Yes, things change. but I also find that the conditions and there are certain foods and refined foods and foods that are generally unhealthy for you, that will be also promoting the get cells in our body to just go haywire and mutate. So be careful. A healthy diet can never be overstressed. Exercise, you said earlier, can never be overstressed. I wanted to put a plug in and ask a question on soy. This is last question. What's your position on soy?
Yeah, soy is controversial, but I think most of the data is coming down in favor of soy being a good product.
Really?
Now, soya belongs to the phytoestrogen, so soy stimulates estrogen receptors in the body. Although it is plant-based, it's still a plant estrogen. So the previous thinking and some of the previous studies suggested that it can function too much like estrogen in the body, but the data is suggesting that soya can probably competitively block the estrogen receptor, and in a way, it can protect against the estrogen influence on the cell. So soya, it seems to be a good product to use.
I'm gonna have to go back and I have to pray about that one a little bit and think about that for me personally, because for years we've had that discussion. You know, you've heard that
Yeah, it
patients are
has
going to
changed.
come
It has changed. Yes, the
and
science
ask
has
that.
changed in terms of
Yeah.
how we think about soya. Yeah.
Okay. So we've
Mhm.
learned. Oh, I can't even think of the amount of pearls and wisdom and advice and gentle approach to the fears, the facts, and the future of where we're going with breast cancer in terms of prevention, knowing your status, getting your test, encouraging your friends, not being afraid. And gents, please, although you're it's 1% or less, if you're really 1%, that's 100% for you. So please examine your own breast, and if you find a lump, seek help from your doctor. Thank you, Mr. Jordan. I hope that he wanted a part two, but we will, Mr. Lewis and Dr. Ian and I will get through. We may decide to do something just especially for men. Hold on while I say that, because next month November is dedicated to all male issues. So we, if possible, we might have Mr. Lewis back for male related surgical breast or other issues. But any no final words to me, Ian. Thanks so much. This was absolutely um eye opening, reassuring as I expected. I'm so sorry I'm frozen, but you guys hear my voice. Um
Thank you, Lana. You
and
know, community education is one of
community.
the main
Yeah. Thank you,
pillars
Miss Pilgrim.
in terms of fighting breast cancer, and thank you for the opportunity.
Right. So any final words for the okay, so you have a spouse and they have a lump and they're like, I'm afraid to get checked. I don't want you come with me. I don't want anybody to know. What would you say?
You know, you said it already. This game has been rallying for long enough that I think fear should not be there anymore. We have good systems available locally that will take care of you. Do not be afraid to enter the system. The system will take care of you. Remember, there are things in terms of prevention of breast cancer. There are things in your domain that you can invoke. You can be physically active. You can work on being overweight, and you can cut your alcohol down to a minimum. Those are things that you can do. A doctor doesn't have to do those for you. But the breast cancer rates, yes, are on the increase, but the mortality is on the decrease. And with sessions like these, and we continue to raise awareness, then we expect people to do better and better.
Awesome. Well said. And I'll just make some comments, just a few comments we missed from the others. Cheryl Pilgrim, who says, very interesting, raising awareness for men. Yvette Jason, she's from Trinidad. So we've reached across the Caribbean. Excellent. She says, very interesting and informative. Thank you. And Miss Green says, thanks so much for the discussion. Very informative. So I can't say any better than that, Ian. Thank you, thank you, thank you. Every time I hear something from you. It's like I'm hearing it for the first time, or it
I, I,
makes it more
I learned
clear.
from you too.
Well, you're just far so kind. This is why we call you the sweetest surgeon that we all know.
Oh,
So, oh
okay.
yes, don't let it go anywhere else, dear.
No, no.
But thank you very much,
Thank you,
and
Lana.
yes,
Thanks,
audience.
everybody.
Next month, November, is Men's Health, so I'll be keeping you in touch with that. Thank you, Mr. Lewis, Dr. Ian, and we will say goodnight from now, from my heart to yours. Like, subscribe, share with a friend, and any questions you have after this, please put it in the post, and I will send it off to Dr. Lewis, and I will get back to you. Thank you all, and have a wonderful, wonderful night.
Thank you. Night, night.
Night, night.
Okay.